Okay, this case study looks at why you graft. So what is a graft? But this one in particular has really good information on why you actually graft a site. And this is an extraction that was not grafted, so you can see what the problems occur when you don't graft a site and try to maintain a facial plate that is coded as red. So in this case, we're looking at this particular tooth, which is one of the primary chewing teeth, but it's also the first premolar, which ends up in your smile line. So when you smile, canine to canine is your 80% of your smile, but you still have more of the smile to happen across and just past that canine position. And that would be the first molar. So this does come into effect. Luckily, this patient doesn't have a high smile line, so this is also a green when you get to lip line on the first part of smile characteristics. So we're not going to talk about those greens on the smile characteristics because that's the only thing that really helps this patient, is that it's not a big cosmetic case. But you can imagine if, when you see this, if this patient had a big gummy smile, how much impact a graft could make in this case, where if this tooth, when it was extracted, had actually a graft done to maintain the space long enough so that bone would actually integrate or hopefully grow into the space that was once where a tooth was. So we're looking at this tooth. We will also be looking at this tooth here. This tooth is fractured at the gum line, and I haven't seen this patient in over 3 years and is actually coming in soon. And this has been fractured for well over 3 years, so it's kind of a miracle that this patient can actually keep something in their mouth. But once again, that's the power of vanity, the smile. Since that hasn't fallen out, she just is very careful of not doing anything because most people don't like dentistry and don't want to deal with dentistry. So, given that, let's take a look at this case here. Let me move the marker over, and we're going to move it to this site here. That's going to be our implant site, and we can see here the tooth where it once was, and it's fairly porous. There's not a lot of bone going on here, and you can see a little thin feather of a facial plate that was once there, meaning that this is the cheek side, this is the bone side, and then here's the socket site, and you can see there's really nothing there. This is actually tissue, so the density that you're seeing here is tissue, which means there's really no bone here. That's really mostly tissue. Very little bone going on here, but it's also very low, and you can see it kind of in a dissolved manner, and there's really not a lot of bone there. And let me go a little bit more over this direction, and you'll see the quality of bone's not bad, but here's the tooth next door, and if we go right down the middle, here's the nerve. You can see on the tooth next door, we really don't have what we would call the facial plate here. So when this tooth gets extracted, you're going to have a void all the way around like this, and you're going to have to help hold the space out here that was once held by the actual tooth. The actual tooth was holding that tissue back, and when it's taken away, everything collapses in, causing a defect. To take a look at that closer, we can see here, here's the patient at this moment of where that CT was taken. And if you can see that concavity, this is the tooth in front, here's the edentulous site. And that's unfortunate. If this person really smiled high and the lip came up really high, you would see that defect very clearly. What happens here is that the implant ends up way up here into the bone, and there's this really thin amount of gum tissue, but you're trying to make the teeth over here look natural and normal, but when it comes to the gum line, you come ditching in, and then the gums go ditching in like this. So it's kind of like the tooth, let's see, the tooth comes in, and it's going to go to the gums, and the gums have to kind of get it and come out again. So there's this real problem right at the gum line where it ditches in. And we'll see that in a second too. Here's another viewpoint of it from a different viewpoint. It's a little bit blurry, but we can see how this tissue just collapsed in because all that bone is collapsed away. And here we're into the detached tissue area here. But here is the attached tissue. Here's how the teeth have natural bone, but the bone is very, very thin on the cheek side here, and here's towards the front of the mouth. That's the canine I was showing you earlier. And the implant goes in here, and you can see that the tooth has to come down and somehow meet into the gums right down here to give it any resemblance of something pseudo-normal. So let's go back to the CT. And this implant was placed into the site, and it was pretty well. We don't have a CT or x-ray of that, but we do have a picture of it here. This is with the restoration in place, and you can see here how we have to kind of come out and maintain the contour of the tooth. The result isn't so bad. The tooth matches pretty well. And now you have this situation where you have this contour, and now you have a ditching in here. Here's another picture of it here. And that's a little more clear. Here's the tooth here, and see how much longer the tooth ends up being. This is a premolar, this is a premolar, and look how much bone, and that bone is way down there. It's not even on the charts here. You can't see it. Anyway, this defect causes us to elongate the bone, or the tooth, I should say, from here. Instead of going into the gums right around here, you have to add a few millimeters of tooth structure, and then you have to ditch it in. One of the problems I have with this patient here, looking at every picture that we've taken since she's been in, and these are all older pictures now, she does not clean her teeth. These, all I'm seeing all around her teeth have a bunch of gunk or a bunch of plaque buildup on every single picture. So I can kind of look the other way once or twice when the patient comes in. Maybe they didn't brush that morning, or maybe it's the afternoon. But when every time they come in and you take a picture, you see the same thing, you have to think oral health care. Oral health care is the problem that this lady's having with probably going to come in. I'm going to see more periodontitis. We're going to maybe even see more recession here. So we'll take an updated picture when she comes in to see really where that ends up. So let's look at the other tooth that I said we look at, which is this front one right in here that is fractured. So this is a tough one to deal with, because now if I'm talking to a doctor to help train them, what exactly would I be telling them in terms of dealing with this tooth? So let's look at this right here. I'm going to bring it a little more. There we go. So here's the tooth here that we're looking at here, but I want to look at now here on the side. You can see how much decayed and rot that this is, but it's kind of interesting because this part is the cosmetic part. This is the chewing functional part. This is not. And by leaving this in, so long as this doesn't get infected, it won't destroy the bone. Actually, it's maintaining the bone out here in this area here. Okay? Here, you can see the fracture clearly going across here and the decay of this tooth. It's kind of rotted away. So I don't know if this patient had it extracted. I don't know. I haven't seen this patient in years. And so what would you do here? If you had this case and you're a dentist, what would you do? Let's look right down the middle of this case here. And if you're going to put an implant, let's just say this is what you got here. This is right down the middle, and you can see we got a little sliver of bone here. That little sliver of bone actually really, really helps. That helps hold that gum line up higher than it normally would. It wouldn't give that giant defect that we saw on the premolar tooth. So that's really helpful, and I'll go across the root, and I see that consistently across, which is very good. My only concern here then would be what do I do about a fenestration? Fenestration means window in Latin or something. So you have now a hole possibly right here. That does matter, but not as much as you think. The tissue will actually stop almost always in that area. It can collapse in more there, but that's not in a cosmetic area, and it's not as a functional area as you might think as well. So if we go back to where would we place the implant, and then what size implant and things like that, let's go back here, and now we can grab an implant, and it's going to be a small diameter implant. This one actually looks really good size. That is a 3 by 8, let's say a 3 by 10. So we can put that one in, and I'm gonna maybe longer. Let's change that. Not giving me a change for some reason. Let's say an 11. From this viewpoint, that tooth is much wider than this implant is. And so that's a concern for immediate placements, is when you have too much of a gap, you will have less predictability as to where the actual tooth structure will, the bone structure will actually heal to. Now, you could possibly combine a graft material with this. I don't like doing that. I don't like having to create something that will create weaker bone around it. But this would be looking at the placement, and I'd probably change this to a little bit of a thicker implant here, just to kind of get a little more stability. You could do something longer. This is an 11.5. She could do a 13 millimeter implant. Length would be good as well. Maybe a little bit wider to kind of shrink out the gappage that you're going to find here to lessen your thing. You can do a custom healing collar here that will help maintain the tissue here, which will help maintain the shape. So this will be a very interesting case to do. You'd get good initial stability, you'd get good placement here. So this could be an immediate placement case here as well. Or you could be more conservative and just do a socket graft. So regardless of the premolar, that was kind of a disaster of a collapse of the non-grafting, you will have a much better outcome here with this facial bone that's going on right here. The quality of the bone looks good. So there's all these good checkpoints for this case. She does have a sinus area here. This is the nasal sinus. When we get into the other sinus area, I would say that would be an orange, and it's pretty straight walled, so I give it a yellow constriction. But otherwise, this is a great case. If somebody is a dentist and is looking at this case, I would say this is actually a good case to try an immediate placement in an anterior zone. You have a very low lip line, so you don't have cosmetic concerns, and you have a very good immediate placement stability, and you have a very thick top or gingival third of bone that's going to hold that space there. So if I were going to tell you, I would say you might want to tackle this one as a first immediate cosmetic case to do, not an 8 or 9. So great, thanks.